Hello everyone, so I am Jason and today we're going to be talking about loop diuretics, specifically its role with the kidneys. So first off, what do the kidneys do? The kidneys, its function is to filter out everything in the blood and manage the concentration of the blood, the pH of the blood, and what should be reabsorbed back into the blood. Alright, so how does the kidney do this? The kidney does this by something called the nephron, and that is what I have drawn over here. The nephron is the functional unit of the kidney. So at the very beginning of the kidney, this is where everything is going to be filtered out of the blood. And then throughout this, some things will be reabsorbed, and then some things will not be reabsorbed, and the stuff that's not reabsorbed is going to leave the body. Alright, so let's talk about the main parts now of the nephron. So we have the proximal convoluted tubule, then we go around, we have the descending loop of Henle, then we have the ascending loop of Henle, we have the distal convoluted tubule, and then we have the collecting duct. So 5 main parts of the nephron. Now the part that we're mostly going to be talking about is going to be this one right here, the ascending loop of Henle, and that's where loop diuretics are going to be acting. Alright, so the 4 main diuretics that are considered the loop diuretics is going to be furosemide, mostly called Lasix, because that's the brand name, that's what people have heard of this as. Then we have Bumetanide, Torsemide, and then Ethacrynic Acid. But pretty much the only one that's going to be used is going to be furosemide. The only reason you would want to use like Ethacrynic Acid is because this one won't react with people who have hypersensitivities to like sulfa. Alright, so let's zoom in now on the ascending loop of Henle, and I have this drawn right over here. So I've written up here, thick ascending loop of Henle, which is right here, another cell, another cell. These are going to be renal tubule cells, which is basically this, between it. On this side is going to be the blood, so blood vessels, and then on this side is going to be the nephron side. So basically, if we look over here, inside here is the nephron side, over here is the blood side, and this colored border is the cells, and that's what we have over here. This is going to be the colored border, basically. Okay. Now, understanding that, what is normal functionality before we can talk about what the drugs are going to be doing? We have something called the NKCC2 transporter, which is sodium potassium chloride channel transporter. And it's a co-transporter, and what it's basically going to do, it's going to reabsorb sodium, potassium, and chloride from the nephron, so inside here, and bring it back to the bloodstream. Alright, now when that happens, we are building up more of a positive charge inside of the renal tubule cells, and this can cause some potassium to exit the cell again. So reabsorbed, and then it's going to be exited again. Now, with the more potassium out over here, this is going to have a similar function. Now we're going to have more positive, because potassium is positive. This is going to interfere with magnesium and calcium. So this is going to cause magnesium and calcium to cross back over to the blood side. Now, unlike sodium and potassium and chloride, how it goes within the cell, this is called transcellular transport. Magnesium and calcium is going to be going around the cells, and that's called paracellular transport. Okay, so now let's say, what happens if we add furosemide to this mix? Furosemide is going to be blocking this transporter. So we're not going to be having sodium coming in, we're not going to be having potassium come in, and we're not going to be having chloride come in as much in this area. So what's going to happen is we're going to have more sodium, potassium, and chloride in the nephron, and it's going to be more excreted from the body. With that happening, we know that water likes to follow sodium and other, high concentration solutes. So if we have more solutes, more sodium, potassium, and chloride in the nephron, more water is going to be in this area. And that's kind of why we have that diuretic action here happening. So some things to consider also now, if we're going to be blocking this transporter, we're not going to be having any more potassium really be coming out here through this channel. This is going to be called the ROM-K channel, by the way. So we're not going to have as much potassium coming out here. And then because we're not having as much potassium coming out over here, we're not going to have as much magnesium or calcium being reabsorbed too. So some things that we can expect to have hypocalcemia, so low calcium in the blood, but we could also have hypercalciuria, which is higher calcium concentrations in the urine. So if there's more calcium in the urine, what is some kind of side effect that we could be seeing happen? We can have more kidney stones because there's more calcium going to be in the nephron. Now, some other things that we could be having is we could be having hypokalemia, which is potassium. And the reason that is, we are not going to be absorbing as much potassium back into the bloodstream from the nephron. It's going to be more excreted. So we're going to have hypokalemia. Same thing with sodium, hyponatremia, because we're not reabsorbing it. And same thing with potassium, not with potassium, with chloride, so hypochloremia. All right, so there's some other side effects that I want you to be aware of, specifically with furosemide, but also with the other loop diuretics. One of the main ones is going to be something called ototoxicity. So what could be happening is you could have something called tinnitus, which is going to be like a ringing in your ear, which is going to be unpleasant. Sometimes it's reversible, sometimes it's not going to be reversible. A way we can reduce the likeliness of this happening is by giving the medication slowly, not as a quick bolus, but as a slower bolus or IV infusion. Another side effect, if the patient is taking lithium, this can cause lithium to build up more in the blood because it's going to be less excreted. So you could have a potential for lithium toxicity occurring. So you may want to reduce the dosage of lithium. Okay, and the last side effect I want to talk about is probably one of the more important ones. When you're taking loop diuretics, you don't want to be taking things like NSAIDs, which is going to be like Advil or Motrin or Aleve, and the reason why is NSAIDs block prostaglandins, and prostaglandins, they are responsible for vasodilation of the afferent arteriole. Now, I don't really have it drawn, but it would be right over here in this area. What will happen is when you take an NSAID, it will cause the afferent arteriole to vasoconstrict, and that will result in less filtration in the glomerulus, which is this little squiggle thing over here. So if you're having less filtration, then you're going to be having less drug, the furosemide, actually be able to get into the nephron and actually work as a diuretic. So in conclusion, kind of with this, if you're taking NSAIDs, it's going to reduce the effects of the loop diuretics. Now, it may seem simple, but loop diuretics, specifically furosemide, is probably one of the most common diuretics you're going to be seeing in patients. And it's also one of the strongest diuretics. Now, again, it's going to act over here in the ascending loop of Henle, and this is where 25% of our salts are going to be reabsorbed. So by blocking that, you're going to take out a lot of the reabsorption, and in the same effect, you're going to have a lot of diuresis. Alright guys, so I hope you enjoyed this video. Like it, subscribe to the channel, and I'll do my best to make more.